My name is Ashley Cow, and today I'll be presenting to you the 2009 H1N1 virus, otherwise known as the swine flu. First, we'll start off with some background information. The H1N1 virus was first discovered in Veracruz, Mexico in April. Soon after that month, 2 more cases were found in California. Quickly within the year, 70 countries were affected, and it was considered a worldwide pandemic. The H1 virus has estimated to kill about 284,000 people, according to the World Health Organization. Moving on to step 2 of the 6-step process, some strengths of the pandemic was that there was significant, strong scientific development. The CDC was able to develop RT-PCR tests that allowed for testing on a wide scale and national level. It was able to be done in multiple labs rather than specifically the CDC lab. Soon after, viruses that came to the CDC lab were no longer characterized using the characteristic approach. It was given a full genetic sequencing and stored in a large database. Some weaknesses include criticism of the World Health Organization's 6-phase system. The pandemic moved from a phase 4 to a phase 5 to a phase 6. And a lot of critics say that this system doesn't capture how deadly the virus is, but rather the widespreadness of it, which is not particularly helpful sometimes. Some opportunities that came out of this pandemic was that there was an increased opportunity for education as well as participation for vaccine treatments that were being developed. Some core issues that came up was that there was a weak intensity of the application of the chains of transmission model. The CDC had encouraged staying home if feeling symptoms or to cover coughs and sneezes, but compared to the 2019 coronavirus pandemic, there are no shelter in place, there are no mask mandates, which definitely affected the rate of transmission. Core issue number 2 is that there was a failure to fully investigate and develop plans of action to protect high-risk communities. The CDC didn't discover that the obese population was hit especially hard by the pandemic. This had led to an inquiry into external factors that could affect a person's susceptibility to disease, such as obesity or underlying illnesses, but this investigation was done much later in the pandemic. Another issue that arose was that the H1N virus was mistakenly named by the swine flu by the World Health Organization. This had led to unfair and harmful welfare practices regarding pigs. For example, the Egyptian government had ordered the slaughter of almost 250,000 pigs, despite the fact that there were no H1N1 virus cases reported in Egypt. Some alternative approaches or recommendations to the process would definitely implement more of a preventative care. Examples of this would be encourage civilians to visit their primary care physicians at least once a year just to make sure that they're still healthy and that they're not at risk for any underlying diseases. Furthermore, this allows physicians to identify high-risk patients and to connect them to treatment as well as education. This coincides with the health belief model, where we analyze a person's susceptibility to disease and we look at their underlying external factors as well. Another approach, the CDC recommends staying home and showing symptoms as well as covering sneezes or coughs. This coincides with this socio-ecological model. It places responsibility on the individual to self-monitor and to protect themselves as well as to protect their loved ones and the rest of their community and nation as a whole. Some recommendations, or more so expansions, that I would make to the discoveries of this pandemic. I would love to set up free clinics that specialize in treating high-risk populations. This doesn't only ensure that they receive primary care, but that they also have a clinic and staff that are trained to handle high-risk populations in a pandemic protocol as well. Furthermore, another recommendation I would make is to connect public health officials with leaders of different ethnic and religious communities. By doing so, this doesn't only allow us to survey the needs of the communities directly from the source, but we can use this relationship to implement programming, training, and education as well. in hard-to-reach communities. I believe this can be done by locating the high-risk populations first through a census data. Then public health officials can reach out to the communities to build rapport. Quickly within the next year, we can implement different vaccination programs, treatment clinics, and monitor how these programs affect the community. Soon after, we can use this data to train staff and implement free clinics in high-risk areas. These clinics are specifically trained and tailored to the needs of the community. Furthermore, these clinics will eventually evolve into only a primary care office as well as a routine max vaccination center. Personally, moving into the 21st century, we have to solve pandemics with a little bit more sensitivity and moving in an upstream mental direction. This means understanding why high-risk populations are high risk and recognizing the struggles of low socioeconomic and minority